Alright guys, so this is going to be local anesthetics. We'll cover everything here on the next slide. So we're going to review your basic neuron anatomy and function, a little bit of the history of local anesthetics, what the chemical structure of local anesthetics are, and how that differentiates your different types and classes. The pharmacology of local anesthetics, and then metabolism, our methods of administration, possible side effects, allergic reactions, toxicity, and methemoglobinemia. Alright, so neurons consist of a cell body, or a soma. They have dendrites that receive signals, an axon that transmits the electrical impulse to other cells or other neurons. Neurons are going to communicate through electrical impulses and chemical signals. And then neurons are responsible for sensory input, information processing, and motor output. They're going to form complex networks that underlie all nervous system activities. Alright, so basic definitions here. And being able to understand this is what's going to affect our ability to understand how the mechanism of action of our local anesthetics work. Here's a picture of what a neuron looks like. Now, of course, there's several different types of neurons, but they're all going to have these basic structures. So dendrites that receive a signal. That signal comes in, it's processed, and then sent out the axon into the axon terminal to the next cell or to the effector organ. But knowing what each little structure in here is definitely important. I feel like at this point you guys probably have a pretty solid grasp on what that is. So just breaking it down a little bit more into your different parts. So your cell body, your soma, your dendrites, and your axon. So this here is a peripheral sensory neuron. Like I said earlier, there's different types of neurons that serve different areas of the body. So these are our sensory neurons in our periphery that receive messages and transport them back to our central nervous system. So when we have insult to injury, or say we set our skin on a hot surface, these dendrites then receive this, goes in the axon, into the cell body, it's processed. That axon carries out the electrical impulse and then into the synapse with the next neuron. Alright, so when axons terminate, they form the presynaptic terminal. Okay, so the next organ or dendrites are right next to the termination, forming that common thing that you guys have heard of, the synaptic cleft. So that synaptic cleft is where we're going to have neurons using exocytosis to initiate an effect on an organ or to send a message to another neuron. So inside that synaptic cleft, the nerve membranes of the postsynaptic neurons have receptors which bind the neurotransmitters released from the presynaptic terminals. Okay, this is what we call a chemically mediated communication, form of communication. This is different from the electrical transmission down the axon. Okay, so axons transmit at the action potentials to the axon terminal that form that presynaptic cleft and the synaptic cleft. Alright, so the conduction velocity of these action potentials through the axon is going to be influenced by a few things, but mainly our nerve fiber diameter and the myelination. Okay, so the fiber diameter, the larger the nerve fiber is, it's going to be able to conduct a signal faster. That makes sense, right? So if I have a small nerve, it can only conduct a certain amount of electricity. But if I have a large nerve fiber, I can send all kinds of electrical impulses. I got all kinds of room to conduct. So the myelination, the more heavily myelinated fibers transmit signals at higher speeds. So when we think about isolating this energy inside the nerve and allowing it to be transmitted efficiently, okay, and not be affected by outside environmental changes. So we have this big, thick myelin sheath on some of these nerves, and it allows that electrical impulse to travel quicker and more efficiently. So when we talk about myelination in the peripheral nervous system, you have Schwann cells, and then your central nervous system, you have oligodendrocytes. And this is what's going to form the myelin tissue on those nerves. So when we talk about impulse transmission and action potential, the nodes of Ranvier or Ranvier are going to be spaces in between the myelin sheath. So this little area right here. Okay, it's where the nerve is exposed. So this is where neuronal conduction is propagated, meaning that that impulse is able to skip from node to node. Now, this is important because it allows these nerves to conduct that impulse faster. But voltage-gated sodium channels are positioned in these nodes, okay? This is the primary site of action of local anesthetics. So right here in that node of Ranvier, that is where our local anesthetics are trying to bind and work. All right, so saltatory conduction is where action potentials jump from node to node, and this increases the speed of nerve conduction. So because of this, when we block these nodes, we have to block 2 or 3, because if I have these consecutive nodes of Ranvier, if I only block one, what do you think it's going to do? It's just going to jump right over it to the next one. So we have to block 2 or 3 consecutive nodes to get an effective block. So when we talk about conduction velocity, so conduction velocity is the speed at which a nerve transmits its electrical impulses, okay? So like we said earlier, dependent on 2 variables, fiber size and myelination, okay? So it also plays a role not only on our conduction velocity, but it also lays back into the onset and duration of our local anesthetic block. And we'll talk about this, about how the different fibers, the speed of conduction, and if you pay attention, that speed also correlates to how efficiently we can block these nerves. How quickly can I get an onset of a block with these different nerve fibers, and also how long does it last on these nerve fibers. So when we talk about nerve fibers, there's going to be these bad boys right here. So A fibers, we're going to have 4 subtypes. We have A alpha, B beta, Y gamma, and D delta. We have B fibers and also C fibers. All right. So starting off with the big dogs, A fibers, the alpha subtype. Okay, they are heavily myelinated. All right, their function is to control skeletal muscle and motor proprioception. All right, diameter is 12 to 20 micrometers. They have the highest conduction velocity of all the nerve fibers. Okay, this means they are 4th in line for block onset. So when we say that, that means that, all right, I administer my local anesthetic. Okay, it affects this nerve first, 2nd nerve, 3rd nerve, and then finally the A alpha nerve. Okay, so they, because they are heavily myelinated and they are large in diameter, it takes longer for our local anesthetics to block them. All right, A fibers, the beta subtype, they're also heavily myelinated. Their function is touch and pressure, Their diameter is 5 to 12 micrometers, so a little bit smaller than the alpha. They have the second highest conduction velocity, all right? But they're also in that fourth in line for block onset. So they're still waiting back here that alpha and beta fibers are. They have these three others that have to get blocked before they do. All right, the gamma fibers, all right, A gamma fibers. They are medium, considered to have medium myelination. Their function is they're going to maintain skeletal muscle tone. All right, a little bit smaller now, 3 to 6 micrometers. They have medium conduction velocity. Now you see a change. They're third in line for block onset. Now A delta fibers. So we've studied these before in our opioid lecture. They're mediumly myelinated. Their function is fast pain, temperature, and touch. All right, this was the acute pain fibers. That's atrocious. Can't even read it. But so quick, sharp pain is what these control. 2 to 5 micrometers. They have a medium conduction velocity and they're third in line for the block. Okay. So far we've got alpha and beta. Alright, and then we have delta and gamma. Okay. But notice these are all A subtypes. But these are third in line and these are fourth in line for block A. Alright, so let's build on that. So now we move on to our B fibers. They're lightly myelinated, and their function is they're preganglionic autonomic nervous system fibers. Their diameter, 3 micrometers, very small. They have a very slow conduction velocity, but they are first in line for block onset. Alright, so we're putting the puzzle together now. B fibers are first. You'll be able to guess what's second. We have our alpha and beta subtypes, and our gamma and delta. Alright. And don't forget that these are A subtypes. This is your true beta. Okay, they're first in line and they control autonomic nervous system fibers. So wonder what happens when we block these. Hypotension. Okay. That's why our spinals cause such bad hypotension. Alright, C fibers. So the sympathetic division. They have no myelination. Their function is the postganglionic autonomic nervous system fibers. They're 0.3 to 1.3 micrometers. They have the slowest conduction velocity. They're second in line, okay, for block onset. So we have our beta fibers, our B fibers, C fibers, and if we just break it down into these two, we know that they're all A fibers, okay? C fibers also have a dorsal root subtype. They're not myelinated as well. But this is the one that we studied for chronic pain when we were talking about opioids. Sensation of slow, dull pain, temperature and touch. 0.4 to 1.2 micrometers. They're a C fiber, so they have the slowest conduction velocity. And they're second in line for block onset. Okay. So B, C, and then our alpha and beta subtypes, and then our gamma and delta subtypes, and these are A fibers. So we're discussing all this difference in size, conduction velocity, and myelination. Well, this leads to what we call a differential blockade. So differential blockade is where the previous types of nerve fibers we just talked about are blocked at different rates or degrees during regional anesthesia. And as we were discussing, this depends on size, myelination, the location of the nerve in the fascicle, and the function. So when we say the location in the nerve fascicle, when we look at nerves under ultrasound, they look like what? They look like a honeycomb, okay? So this honeycomb structure is actually showing us the different nerve fibers. So their location inside that fascicle also is going to say, if I have local anesthetic building up all around this nerve fascicle, we just did an excellent block. Okay, we just made a huge donut of local anesthetic around this nerve fascicle. Well, of course, these nerve fibers that are on the outside of this fascicle are going to be blocked more readily, right? That local has to penetrate through those and then into the inside of that fascicle. So that's what we're talking about there. All right, and then also the function is going to depend on the differential blockade. So this right here is super, 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 super important, okay? Understanding your block order, okay? Front to back and back to front. So first we block those autonomic fibers, which are your B fibers. They're the first to be blocked. This is going to lead to the loss of vasomotor tone, hypotension. So this is when we're doing a spinal and for your C-section. The first thing I tell patients, if you start to feel sick at all, tell me, because when patients get hypotensive, especially your pregnant mamas, they get sick and they start to get nauseous, okay? They get nausea and vomiting. And if you pre-treat this hypotension as soon as they start to feel sick, a lot of times you prevent the latter part, that vomiting, and you keep mama and baby safe. Alright, so after our autonomic, we're going to block pain and temperature fibers, which are C fibers and A delta. Okay. Alright. And then touch and pressure fibers are going to be next, which are A beta fibers. They're blocked after our pain fibers. This leads to loss of tactile sensation. And then our motor fibers, A alpha, are the last to be blocked. This results in muscle weakness or paralysis. Okay. So when we have a really dense block, if I do a brachial plexus block on a patient, and I go up and ask them to give me a high five, and they can't even lift their arm up off the bed, I know that I've got a really dense block, and I've blocked those A alpha fibers. Minimum effective concentration, or CM, is going to be measuring the concentration required to block nerve conduction. Okay, it's similar to your MAC value or your ED50. So a lower CM is going to correlate to nerve fibers that are more easily blocked. And if we think about this, what nerve fibers would that be? Well, it's your B, C, your B and your C fibers. All right, so as we go up in blockade, okay, we know that this fiber, your B fibers, are going to have a lower CM value than your C fibers, and so forth. So CM is also affected by physiological variables, so tissue pH, and then also how frequently is that nerve stimulated. And we'll learn about a little bit more about this here in a bit. So as with all of our drugs, they all have a history, and I think it's important to understand the history just to know where we came from and how developed these drugs are now that we're using today. So all the way back to the ancient Inca tribe and civilization in South America, they chewed leaves from the cocoa shrub, which was known for its fatigue abolishing and mood elevating effects. Well, that was also the cocaine plant. But European explorers were said to take this cocoa syrup back to Europe, where chemists attempted to extract the active ingredient. In 1855, Gadoc was able to extract the alkaloid urothoxylin from the leaf, and in 1860, Albert Niemann isolated cocaine from that urothoxylin. Okay, during his research, Niemann observed that the crystals numbed his tongue. All right, and in the early 1880s, Karl Kohler, using cocaine supplied by Sigmund Freud, successfully anesthetized the cornea in several subjects. Then Kohler presented a paper on the topical application of cocaine in 1884. This led in 1885, William Halsted and John Hopkins began blocking nerves by injecting them with cocaine. Okay, this really marked the beginning of our regional anesthesia and local anesthetics. So all the way back to 1885, so that's a long, long time ago. In 1885, James Corning published his findings in the New York Medical Journal and on the use of peridural injections of cocaine. So some of the first epidural or dural space injections. 1889, Augustus Beer reported using subarachnoid cocaine to anesthetize patients for surgeries. During his research, Beer and his associate, Dr. Hildebrandt, administered lumbar cocaine anesthesia on each other. So that's pretty interesting. They were performing spinals on each other. Both Beer and Hildebrandt developed spinal headaches that lasted for several days. As a result, Beer recommended bed rest for patients receiving spinal anesthesia. All right, cocaine, local anesthesia, also came with its own troubles. So many of the pioneers of the drug also became addicted, and in the first 7 years of its use, there were 13 deaths in just one facility. Okay, this led to the practice fading away. And then in 1905, Albert Einhorn created Procaine, and local anesthesia became popular again. Then continuing on, during World War II, Robert Hingson started to use malleable needles to infuse local anesthetics deep in the peridural ligament. So this is some of your epidural treatments. Bupivacaine came to the market in 1965, and its cardiotoxic side effects also led to the discovery about its mechanism of action. Okay. In 1996, ropivacaine was developed as a pure S enantiomer, which is compared to bupivacaine, which is a racemic mixture. So just a brief history there. Not going to be tested on any of this, just understanding where we came from with the history of these local anesthetics. I think is important for your all's understanding of locals. When we start to look at the molecular structure of local anesthetics, they're going to be made of three main structures, okay? A benzene ring, intermediate side chain, and then a tertiary amine. Each one of these is going to provide certain properties that allow our local anesthetic to work, okay? Let's get a little bit further into depth of what each one of these looks like. So because we already studied these functional groups and the benzene rings and our tertiary groups, you guys should be able to pick up on this pretty quick. So our benzene ring is that aromatic ring, okay? It's lipophilic. This is our intermediate chain. This is what's going to discern between our two separate classes of local anesthetics. We have amides and esters. All right. Then our quaternary amine or our tertiary amine is going to be hydrophilic, and that's what's going to give the molecule its other side of the tail. So, knowing these groups right here is going to be extremely important. We start to look at amides. So amide local anesthetics are going to undergo metabolism by the liver and the CYP450 enzyme system. Their elimination is going to be relatively slow and accumulates in the bloodstream. So what does that mean? When we have things that accumulate in the bloodstream, they're more likely to cause toxicity. A little cheat code, all the amides have two I's in their names, okay? So we have amides here, and this is what your chemical intermediate chain is going to look like. All right. So it's going to be important to be able to identify them not only by their name and also by their structure. Here's a list of some of the commonly used or tested on amides. So articaine, levobupivacaine, dibucaine, lidocaine, atidocane, prilocaine, mepivacaine, bupivacaine, and ropivacaine. In my current practice, ropi, bupivacaine, mepivacaine, and lidocaine are going to be really the four that I most commonly use, and all for different reasons. When we start to talk about ester local anesthetics, they're going to be predominantly metabolized by undergoing hydrolysis by pseudocholinesterase or plasma cholinesterases. Okay, ester hydrolysis is generally rapid, and metabolites are excreted in the urine. But this is what's interesting about esters is para-aminobenzoic acid, or PABA, is a metabolite of esters that has been associated with allergic reactions. So when we have patients that have a true allergy to esters, it's most likely due to this metabolite. Systemic toxicity is inversely related to the rate of hydrolysis. That makes sense because if we have slower metabolism, we have an increased risk of toxicity. Patients with abnormal plasma cholinesterase will have an increased risk of developing systemic toxic levels. So some of our common ester local anesthetics are going to be benzocaine, cocaine, chloroprocaine, procaine, and tetracaine. So if you'll notice, something that should key you off if you see these local anesthetics on an exam question, they only have one eye. All right, your amides have two eyes, your esters only have one. Okay? So when we talk about local anesthetic allergic reactions, first off, it's extremely rare to have a true allergic reaction to local anesthetics. But esters, because of that metabolite, para-aminobenzoic acid, they're going to be more commonly the cause of allergic reactions, okay? Also, if a patient is allergic to one ester, they're allergic to them all, okay? But the good thing is if the patient's allergic to an ester, so say they're allergic to procaine, there are no cross allergies between esters and amides, all right? So we're able to use an amide if they're allergic to an ester, or if they're allergic to amides, we could use an ester. Okay, so when we start looking at the mechanism of action of local anesthetics, they're going to bind the sodium channels on nerve fibers in two of the three states that these sodium channels exist in. Okay, they're going to bind in either the active or inactive state. All right, and this is talking about the state of the channel, that sodium channel. When we bind that alpha subunit on these sodium channels, this is going to block the conduction of impulses and change the membrane potential. All right, when we change the membrane potential, it's going to leave the neuron unable to conduct them and transmit impulses. So when we think about how nerves build a charge, this is what we're blocking. We're blocking that charge from building up and continuing to conduct through the axon hillock to the axon terminal, and to prevent it from being able to communicate with the next neuron, which in turn is going to prevent that painful stimulus that we don't want the patient to feel from getting to the patient's brain. Okay. So to understand this, you have to know, what is our resting membrane potential in a nerve? So resting membrane potential of a peripheral nerve is usually between -70 to -90 millivolts. Okay. The resting membrane potential is going to be created by an electrolyte gradient between the axoplasm and the extracellular fluid. Okay, so axoplasm is the axon that we've been talking about this whole time, and then your ECF is the fluids that's surrounding it. So the sodium-potassium pump, which you guys I'm sure are familiar with, is primarily responsible for maintaining this resting membrane potential. So when we talk about membrane potential and that sodium-potassium pump, we know that it's ATP dependent, okay? It takes energy and it pumps 3 sodium molecules out and 2 potassium molecules back in, okay? This is all an effort to get back to the resting membrane potential that's normal for that nerve cell. All right, when we create this gradient, it's going to favor the diffusion, right? Anytime we have a diffusion gradient, it's going to want one molecule to go one way and another molecule to go the other, okay? All right, so when we generate an action potential, all right, and those action potentials is what we've been talking about this whole time. That action potential creates an impulse, and then that impulse has the conduction velocity, and that goes through the nerve. So action potentials are going to be generated by stimulus, okay? That can be a mechanical, chemical, electrical, or thermal stimulus. And neurons are going to contain that voltage-gated sodium and potassium channels that open in response to these stimuluses, okay? So the stimulus will build the charge in the neuron until a threshold has been met, which is usually about negative 50 millivolts, and depolarization will occur. So, threshold. Anytime we think about threshold, it's going to be thinking about, okay, how much do I have to change the state, the resting state of whatever I'm trying to depolarize. So the closer your resting membrane potential and threshold are, the easier it is to depolarize whatever that cell is. So next we depolarize the cell, right? So when the nerve depolarizes, sodium channels are going to open. Sodium flows into the neuron, okay? This is going to send the neuron into a positive state. We're raising the charge. All right, this briefly sends the membrane potential to a positive charge, around positive 30 millivolts, okay? After this brief opening, the sodium channels close into their inactive state. Then the potassium channels open and potassium leaves the cell to bring the resting membrane potential back down to negative 70 millivolts, okay? So once that resting membrane potential is met, the cell has officially repolarized. Okay? So we discussed that sodium channel exists in 3 different states: resting, active, and inactive, okay? So resting is at resting membrane potential of negative 70. Active is when the threshold potential has been met and the channel opens, so that big rush of sodium in. Inactive is when the channel is closed to allow the resting membrane potential to be restored. Okay, so the refractory period, right, which was common, we talk about this in the heart as well. This is when the voltage-gated sodium channels are in the inactive state after depolarization, okay? This is known as absolute refractory. So during this period, no other action potential can be generated. Once these local anesthetics bind to that sodium channel, they lock it in this inactive state, okay, preventing the impulse from being created. So once we get that local anesthetic to bind on that sodium channel, okay, and then alpha subunit, it's going to lock it in an inactive state where sodium can't leave or enter the cell. Alright, so this is what I was just saying. Local anesthetics reversibly bind to the alpha subunits. That's important, right? They reversibly bind, so we can get rid of them. They eventually metabolize out. Alright, so the alpha subunit of the voltage-gated sodium channel is where they bind. Activation of this receptor plugs the channel and allows sodium to rush into the that allows sodium to rush into the neuron. Okay, so locals can only bind to the channel in the active and inactive state. The open or inactive states expose the inner pore of the sodium channel that allows the anesthetic to enter and block ion conduction. Okay, in the resting state, the channel is structurally closed, so the local anesthetic cannot easily reach its binding site within the channel. So this is why we have a phasic blockade. Okay, so a phasic blockade, if we think about it, we want these sodium channels to cycle through the active and inactive state. All right, so how do we do that? Well, if I make you move your arm, or you're using that extremity more frequently, you're activating those neurons that are inside that nerve cell. You're activating that nerve. So the more you activate it, the more it's going to cycle through all those three phases. And that local anesthetic is going to have more opportunities to bind to its active site and create an efficient or a deep blockade. So it gets a little bit more in depth here. So local anesthetics mostly are weak bases. All right. So if we think about weak bases, it's going to have an alkalotic pH, meaning that it's higher. It's a higher pH values than our physiologic pH. So after we inject a local anesthetic, okay, locals are going to dissociate into an ionized conjugate acid and an unionized portion. Okay, the unionized portion is what we're concerned about just after injection, because that is the portion of the local anesthetic which is more lipid soluble. Okay, that penetrates the nerve. But once we get inside of the nerve, the unionized portion is going to dissociate again into that conjugate acid and unionized portion. But this is where it's cool. The ionized portion, or conjugate acid, is the portion that then binds to the alpha subunit of the sodium channel. So we have two separate dissociations that occur in two separate environments. If you think about it that way, it's easy to remember, because when we inject it in the extracellular fluid that has a certain pH, it dissociates. That unionized portion then penetrates into the nerve. Well, the inside of that nerve and the nerve cell has a different pH as well, so then it dissociates again. But this is also what leads to what we call ion trapping. So when we give local anesthetics to a mother, they can enter the circulation in an unionized form, which remember is very soluble, very lipid soluble. It crosses the placental barrier pretty easy, but then once it crosses the placental barrier, we know that fetuses have a much different pH. It's usually a little more acidic than the mom's pH. Okay, that local dissociates again. Okay. And then more of the local becomes ionized. Okay, the ionized portion of the local can't cross back into the maternal circulation, so you can have a buildup of that molecule inside of the fetus, which, as we know, anytime we talk about a buildup of any sort of molecule, it's usually not good. We don't want that. So this is something to be cognizant of, and that we'll talk more about when we talk about fetal circulation. Okay, so big things when we talk about locals: potency, duration, and onset. Okay, potency is going to be directly related to your lipid solubility. Okay. Duration of action is going to be directly linked to your protein binding, and then onset is a function of pKa. So just reviewing some of these key factors of our local anesthetic. So potency is going to refer to the amount of drug required to achieve a therapeutic effect. Okay, so the potency of local anesthetics is going to link, like I said, to their lipid solubility. And then also we can change the potency due to our dose and concentration, but overall lipid solubility is the most important thing when we're talking about potency. Duration of action depends on both lipid solubility and, more importantly, protein binding. Okay, drugs with a higher affinity for proteins and lipids tend to bind more strongly near the sodium channels, okay, reducing uptake into the bloodstream. So we're keeping them at the site that we want them to be active. So when we have drugs that wear off, that local anesthetic wears off around our site, these protein-bound molecules then break off and bind with these sodium channels, creating a longer blockade. Onset of action depends also on lipid solubility, chemical structure, but primarily the state of ionization. So we know that we have to have that unionized portion to go into the nerve and then dissociate again, and that ionized portion inside the cell is what binds to that sodium channel. So the pKa have a weak base at the pH of which 50% of the drug is ionized and 50% remains unionized. So the local anesthetics with the pKa closest to physiological pH are going to have your fastest onset of action because we're going to have a more unionized drug to penetrate into that nerve. So if we think about other ways that we can increase our duration, if we limit that blood flow to the tissue or vasoconstrict that area around the tissue, then it's going to decrease its uptake into the bloodstream. In general, local anesthetics are going to cause relaxation of vascular smooth muscle. Okay, this is going to lead to vasodilation and increased blood flow to that tissue. So as a result, the drug's absorption is enhanced, okay, which is going to shorten our duration and increase the risk of toxicity. Always an outlier, cocaine is the only local anesthetic with vasoconstrictive properties. All right. Some sources also suggest that bupivacaine and ropivacaine exhibit a biphasic effect. So when we start thinking about systemic absorption and blood flow, it's important to know, okay, well, where are our absorption rates? In other words, what areas of our body have the highest amount of blood flow that we commonly inject? Of course, we know that our brain has a very high blood flow, but I don't think any of us are planning on injecting any sort of local anesthetic into patients' brains, right? So, obviously, IV is going to have a huge, as soon as we inject it into the IV space, we're increasing that concentration. Next is tracheal, intrapleural, intercostal, caudal, epidural, the brachial plexus, femoral, sciatic, and then sub-Q. Okay. And then also we inject locals, but it's usually in very small, low concentrations into the spinal cord meninges. They play a great role in distribution of local anesthetics from the epidural and subarachnoid spaces. Okay, so the skin acts nearly as a complete barrier to local anesthetics. That's good because when I accidentally get lidocaine or ropivacaine on my hand when I'm drawing it up, I don't end up absorbing it. But the exception is EMLA cream. We're going to talk more about EMLA cream. It's designed to go in through your, transdermally. All right. So again, pKa is going to be important when we're talking about local anesthetics. So it's directly related to our potency and onset. As the pKa gets higher or more basic, more alkalotic, our ionized portion increases in our initial dissociation. Like I said, the closer that pKa is to physiologic pH, the faster the onset of our drug. So drugs that bind strongly to proteins also is going to increase their duration. We talked about that. So let's take a look. These values are going to be important that you understand you have a general idea about. So if we look at our amides, the highest pKa is going to be 8.1. Our esters, the lowest pKa is 8.5. So you know automatically if you get a pKa value that's above 8.1, it's got to be an ester. Okay. So then we look at what is our duration of action linked to? It's our protein binding. So commonly, percent protein bound as to our amides is going to be higher. All right, and that makes sense because these have a longer duration in general than most of our esters that we commonly use. All right. So let's get into a little bit of the individual anesthetics here. So amide local anesthetics. Lidocaine. Remember, it's got the two I's. It's got a fast onset. It's intermediate duration. So this is what we use for a isolated nerve block of the median and ulnar nerve the other day when I took care of that guy that had a cat bite, and we had to debride his pinky finger. So we did an isolated nerve block with some lidocaine. He had good anesthesia for about 2 hours, and we were able to do the procedure safely. So uses are going to be topical, IV, peripheral nerve block, epidural, and spinal. Max dose, 4.5 milligrams per kilo, or a 300 milligram max, or 7 milligrams per kilo with epi, which is 500. All right, the pivocaine, okay, another amide local anesthetic because we have two I's. It also has a fast onset and intermediate duration. Uses are infiltration, peripheral nerve block, epidural, and spinal. Most commonly, we use this for our spinal doses for our total joints at our main hospital due to its a little bit shorter duration than bupivacaine. Spinally, it gives you about 2 good hours, 2.5 good hours of spinal anesthesia. Max dose is going to be 7 milligrams per kilo or 400 milligrams. Okay, this is talking more about peripheral nerve blocks and infiltration here. All right, Prolicaine has a fast onset, intermediate duration. So the uses are going to be infiltration, peripheral nerve block, IV and epidural, and then max dose is 8 mg per kilo or 500 milligrams if the patient's less than 70 kilos, and then 600 milligrams if they're greater than 70 kilograms. And this causes this weird thing possibly called methemoglobinemia. So remember this, Prolicaine is associated with methemoglobinemia, and we're going to talk about this at the end of this lecture. So bupivacaine, if we remember correctly, this is one of the first amides other than Prolicaine that was created. So bupivacaine also goes by Marcaine or Sensicaine. It has an intermediate onset but a very long duration. Okay, uses are going to be infiltration, peripheral nerve block, epidural, and spinal. This is a common anesthetic that comes in your spinal trays. Okay, max dose is 2.5 milligrams per kilo or 175 milligrams. So look how little you can give this compared to the past few anesthetics we've been talking about. Okay, that's because it's very cardiotoxic. Accidental IV injection of even small doses can lead to irreversible heart block and precipitous hypotension. Irreversible heart block sounds like a bad time to me. So that's not something that we want to do. Pregnant patients and patients on antidysrhythmics are going to be more susceptible to these effects, okay? Ropivacaine is probably our most commonly used anesthetic for our peripheral nerve blocks. It has a slow onset and a long duration. Max dose is 3 milligrams per kilo or 200 milligrams, okay? It's much less cardiotoxic because it's not a racemic mixture like bupivacaine. It only has that S enantiomer. All right, so it's less cardiotoxic, making it a lot safer for us to use. Another amide local anesthetic that's important, but we don't use it commonly for anesthetizing or providing, anesthesia, is dibucaine. It's used primarily for testing cholinesterase deficiencies, okay? What's interesting about dibucaine is it strongly binds to our pseudocholinesterase. So atypical pseudocholinesterase is not going to be bound nearly as strongly to leading to less inhibition of the pseudocholinesterase activity. So when atypical pseudocholinesterase is suspected or detected in patients, a dibucaine number or test can be ordered. So if we remember, pseudocholinesterase deficiency is what allows us to, pseudocholinesterase allows us to metabolize things like succinylcholine. So if we have a pseudocholinesterase deficiency or atypical pseudocholinesterase, it leads to a prolonged duration of action of succinylcholine. So this can be important when we're going to reverse patients and, extubate them and get them to PACU if we've given them sucks and they have, atypical or a homoatypical type of pseudocholinesterase that doesn't work at all, they can be paralyzed for up to 1 to 6 hours off of 1 dose of succinylcholine. So if we look at this little table here, normal pseudocholinesterase, we have a duration of succinylcholine being 6 minutes, okay? Their WK number is going to be around 80. Incidence of this is really common, okay? That's supposed to be another little 0 right there. All right, so hetero, having some normal and some atypical. All right, 15 to 25 minutes. So just a small decrease in the amount of pseudocholinesterase you have to metabolize that drug is going to increase the duration drastically. All right, the WK number is going to be around 50. Incidence is 1 in 475 patients. Homo or atypical meaning that all of their pseudocholinesterase is atypical. 1 to 6 hour duration of succinylcholine, okay? So you do a 1 hour gallbladder on a patient and you give them sux for induction. You got to wake them up and they're awake completely, but they're still paralyzed. So that's a big deal, all right? We can't safely extubate these patients. So that's why we ask, family members and patients, hey, has anybody in your family ever had to be, intubated for a long time after anesthesia for any reason? And that usually is what we're alluding to. Their WK number is going to be around 20. Incidence is 1 in 3,300 patients. So it's still, that's not uncommon. All right. So it's something to be aware of. Actually, one of the CRNAs that I know that I worked with as a student, she has complete atypical pseudocholinesterase. All right. So moving on to esters. All right. Cocaine is going to be one of our esters. Remember, esters don't have the 2 eyes, so it has a fast onset and short duration. In anesthesia, we don't really use this. All right, it's mostly used for topical anesthesia and infiltration with ENT. It blocks reuptake of norepinephrine and dopamine, so that's where we get our hypertension, vasoconstriction from. It can cause coronary artery spasm, hypertension, tachycardia, and MI and VFib, okay? So if we have an ENT doc that wants to use this, we want to use it cautiously in patients with pre-existing hypertension and coronary artery disease. And then there's all this talk about if we have a patient that comes in acutely intoxicated or high on cocaine, and we have all this huge vasoconstriction, and we do a beta selective blockade on these patients before we get that blood pressure down, what can happen? Well, it can cause severe bradycardia and cardiovascular collapse due to blocking that beta, and we have that huge high afterload the heart's trying to pump against. So it's metabolized by plasma cholinesterases, and it usually only shows up in the urine drug screen for 24 to 36 hours. Procaine, or Novocaine, has a slow onset and a short duration. It's primarily what's used for dental and spinal anesthesia, but mostly dental. Max dose is 7 mg per kilo, which lands anywhere between 350 to 600 milligrams. First local synthesized after cocaine, and it's hydrolyzed to that para-aminobenzoic acid, which has that allergy potential. And then chloroprocaine has a fast onset and short duration. It's used for infiltration, peripheral nerve block, and epidural. It has a high max dose of 11 milligrams per kilo, or 800 milligrams without epi, and then with epi, 14 milligrams per kilo, or 1,000 milligrams. So it's hydrolyzed faster when compared to other esters, accounting for its very short duration and low risk for systemic toxicity. That's why you see such high doses here. But it, interestingly, reduces the effectiveness of opioids. Tetracaine is, out of our esters, the longest acting. Okay, it has a slow onset and a very long duration. Okay, we have to give very, very small doses of it. All right, max single dose is 20 milligrams. So that's a huge decrease in the max single dose. Okay, uses spinal, topical anesthesia, and ophthalmic drops, but spinally is the only time I've seen it used from an anesthesia provider. We have benzocaine. Okay, it has a fast onset, a short duration, but this is cool. It's the only ester that is a weak acid. Okay, so we use this for topical anesthesia only, which anesthetizes mucous membranes and primarily for awake intubations. Okay, this is contained in the cetacane spray along with tetracaine. Usually lasts 30 to 60 minutes, and then doses higher than 300 milligrams can produce life-threatening methemoglobinemia. We're going to talk about what that is here in just a bit. So how do we use local anesthetics? Well, obviously we have topical. The topical route of administration involves placing the local anesthetics directly onto mucous membranes. Okay, we talked about this in the lidocaine lollipop. We'll place it in the nose, the mouth, tracheobronchial tree, the esophagus, or the GU tract. Commonly used local anesthetics from us are going to be lidocaine and tetracaine, and then cocaine from your ENT docs. Nebulized lidocaine can cause bronchoconstriction in our asthmatic patients, so if we do that, we need to make sure that usually they use a albuterol treatment in conjunction. Typical dose for this is going to be 3 to 5 mils of 4% or 5 mils of 2%. That's going to be nebulized at 6 liters per minute over 10 to 20 minutes. Okay, it's important that when we're nebulizing a patient for an intubation, if we're going to nasally intubate them, then we want them to breathe through their nose. If they're going to orally intubate them, then we need them to breathe through their mouth, because we want that local anesthetic to hit those mucous membranes. All right, eutectic mixtures. So eutectic mixtures are eutectic mixtures of local anesthetics shortened into Emla-cream work by diffusing through the skin to block neuronal transmission from dermal receptors. Okay, so the melting point of the combined drugs in the eutectic mixture is lower than that of lidocaine or prilocaine individually, so this facilitates easier absorption. So 5% Emla-cream is going to be 2.5% lidocaine and 2.5% prilocaine. Okay, so analgesia is going to be produced within 1 hour, and peak effect takes 2 to 3 hours after application. So we don't commonly use this. Okay, so we're never going to apply this to mucous membranes or skin that's not intact, and then after application, an occlusive dressing should be placed. Local infiltration involves the extravascular administration of local anesthetics, or for procedures like IV cannulation, postoperative incisional anesthesia. Lidocaine and bupivacaine are going to be most commonly used for this. The duration of anesthesia, like we said, can be doubled with the addition of epi, so 1 to 200,000, so 5 mics per ml. Caution, okay? We do not inject epinephrine with local anesthetics in areas like fingers, ears, noses, or penis, or any genitalia area. That vasoconstriction may result in ischemia and gangrene, so nobody wants gangrene or ischemia in any of these structures, right? Alright, so one that we all love, peripheral nerve blocks. So this involves injecting local anesthetic solutions into the tissue surrounding nerves or nerve plexuses. So like a femoral block, brachial plexus, axillary block, digital blocks, and so forth. Duration of anesthesia can last up to 14 hours. So this is great pain relief for our patients post-operatively. They're in PACU, happy as a clam, just sitting there eating their crackers because they have no pain. The duration also can be prolonged with the addition of epinephrine according to some sources, but this isn't commonly done. I've never seen it done. And again, if you ever add epi, you want to avoid small vasculature, okay? Anesthetic mixtures combining anesthetics such as lidocaine with bupivacaine can result in a faster onset of anesthesia with prolonged duration. So you mix a quick onset with a long duration, you're going to get that deep block to set up quickly, and then the duration from your bupivacaine. Then we have intravenous regional anesthesia, which is also known as a beer block. All right, this technique involves placing a local anesthetic into an extremity vein that is isolated from the systemic circulation using a tourniquet. All right, the result is profound anesthesia and skeletal muscle relaxation of the affected extremity. So to do a beer block, we're going to start an IV distally in the extremity that will be blocked. A tourniquet is going to be inflated on the extremity to restrict blood flow after we raise the arm. So we're going to raise that arm up. Say if we're doing a carpal tunnel on the left arm, we're going to raise that left arm up. We're going to exsanguinate it with gravity, and then we're going to use an S mark to get the rest of the blood out. We're going to inflate that tourniquet. Usually you want it at least 100 millimeters of mercury higher than your systolic pressure. usually at somewhere around 250 or 200. Once that is inflated, we take that IV that's in that distal extremity and we're going to inject your local anesthetic. So the key here is going to be higher volume. Okay, so lidocaine 0.5% plain is injected through the IV with a 300 milligram max dose. All right, so after 20 minutes, okay, a minimum of 20 minutes, the tourniquet can be released, allowing the local anesthetic to dilute into systemic circulation. Depending on what local anesthetic, you can get a longer duration of anesthesia in that extremity, but it just kind of depends on the culture of your facility. Epidural and caudal injections. So it's performed by injecting local anesthetic into the epidural sacrocaudal space. Mechanism of action is through diffusion, which accounts for the delayed onset, right? Local anesthetics diffuse across the dura to act on nerve roots in the spinal cord, and they also diffuse in the perivertebral area, producing a perivertebral nerve block. All right, so commonly used local anesthetics for this are lidocaine, chloroprocaine, bupivacaine, ropivacaine, and combinations of these agents. All right. If we do use chloroprocaine, we want to administer it before bupivacaine because it can decrease the effectiveness of bupivacaine. And then adding opioids is pretty common to your epidurals, and that can improve your analgesia effects of that epidural. We talk about spinal anesthesia. All right, so it's achieved by injecting local anesthetics into the lumbar subarachnoid space. All right, so below L2, which is commonly where the adult spinal cord ends. Okay, so the primary sites of action are going to be the superficial layers of the spinal cord, the preganglionic fibers as they exit the spinal cord. So very, very small doses are required for these. Okay, so commonly used local anesthetics is bupivacaine and tetracaine, and we also, like I said earlier, use mepivacaine. But 0.75% is the concentration that usually comes with that bupi in your kit, so that's 7.5 milligrams per ml. And we only use 1.4 to 2 mLs, okay? The dose range depends on your height of your patient and how high you want your blockade to go. I mean, if we think about that, that's, you know, a very, very small amount compared to what we infiltrate. You know, your max dose for infiltration is 150 milligrams for bupivacaine, so it's a huge decrease. All right, so some big side effects or complications of anesthesia. So local anesthetic systemic toxicity and methemoglobinemia. So when we discuss local anesthetic systemic toxicity, okay, this is where the plasma concentration is going to depend on the net balance of vascular uptake relative to the redistribution and metabolism of that local. So the most common cause of local anesthetic toxicity is going to be inadvertent IV injection during regional anesthesia. Remember that, okay? That's a reason that we aspirate while we're doing blocks, okay, is to prevent inadvertent IV injection. Most common symptom of LAS is going to be a seizure, okay, except with bupivacaine, we talked about that cardiotoxicity. Cardiac arrest is going to be your symptom of LAS with bupivacaine. So systemic toxicity produces progressive and predictable signs and symptoms of CNS toxicity, okay? If left untreated, it leads to cardiovascular collapse. So here are those progressive signs, all right? I would definitely remember these for your clinical practice and also for the exam. So we start with lightheadedness, tinnitus, circumaural, and tongue numbness. So we think, you know, that's pretty normal. We inject some lidocaine during induction and the patient starts to hear ringing in their ears. Maybe they have like a metallic taste. Their tongue feels funny. That's totally normal. But when they start to have visual disturbances, we know our concentration's increasing, then muscular twitching, convulsions, unconsciousness, they're in a comatose state, they have respiratory arrest, and then cardiovascular system depression or collapse. Okay, so see how those progress. So if we start to have a patient that is starting to have twitching and then they start having convulsions or seizures, we know that we're getting into a very toxic level and we need to get the last cart and start to give some the liposomal treatment. Okay, so factors that increase our risk for LAS. That's going to be hypercarbia, Okay, so it increases cerebral blood flow and decreases protein binding. Hyperkalemia, which raises our resting membrane potential, making neurons depolarize easier. And metabolic acidosis, okay, this is going to decrease the seizure threshold and increase the ion trapping inside the brain. All right, so last, cardiac symptoms. So we alter that cardiac action potential, we decrease automaticity and conduction velocity. Okay, so depression of the myocardium by impairing our calcium regulation as well. So this is a biphasic effect on vascular smooth muscle, producing vasodilation at therapeutic levels, decreasing SVR. So risk for cardiotoxicity, obviously we know bupivacaine is the biggest one. Levobupivacaine, which isn't commonly used, and then Ropi, then lidocaine. So I definitely would remember that bupivacaine is your number one risk for cardiotoxicity. So how do we treat this? Prevention, we use test doses and increment dosing with periodic aspiration. That's going to be your best prevention. And then management of the airway, so we're going to provide 100% FiO2. If we allow the patient to become hypoxic and acidotic, that's going to make our local anesthetic toxicity worse. We're going to treat seizures with benzodiazepines. If benzos are unsuccessful, a small dose of Sux or non-depolarizer to stop muscle contraction. Small doses of propofol are okay, but large doses can worsen myocardial depression and cardiovascular collapse. And then ACLS changes. We're going to use amiodarone as a ventricular dysrhythmic choice. We don't want to use lidocaine, obviously. We're going to avoid large doses of epi and avoid vasopressin if we can. Okay, so if our patient is over 70 kilograms, we're going to give a lipid emulsion therapy, okay, a bolus of 100 mLs over 2 to 3 minutes, and then we're going to infuse 250 mLs over 15 to 20 minutes, okay. If the patient is unstable, we're going to repeat that bolus or double the infusion, all right. If the patient weighs less than 70 kilograms, so this is going to take your bolus to 1.5 mL per kilo of lean body weight over 2 to 3 minutes, okay? Infusion rate is 0.25 mLs per kilo per minute, all right? If the patient remains unstable, repeat bolus dose or double the infusion. The max dose in parentheses, okay? And the reason it's in parentheses, I'll tell you in just a second, is considered to be 15 mLs per kilo. Usually if you've not resolved their symptoms by this point, that means that you have to think about other etiologies that can create similar symptoms, okay? So it's not that this causes an adverse effect, it's just that if we have not seen a resolution in some of the symptoms by 15 mLs per kilogram, then we need to start thinking about secondary diagnosis and other things that could cause our patient to have this sort of presentation. All right, methemoglobinemia. All right, methemoglobinemia is where high concentrations of methemoglobin, all right, in the blood leads to tissue hypoxia. So when we think about methemoglobin, it involves the ferrous form of hemoglobin, which is Fe2+, being oxidized to the ferric form, which is Fe3+. Hemoglobin is then reduced by its capacity to carry oxygen. So methemoglobinemia can't carry nearly as much oxygen. So this causes a shift to the left of the oxyhemoglobin dissociation curve. And normal methemoglobin levels are going to be less than 1%. Okay, so signs of methemoglobinemia. Pale gray or blue colored cyanosis, chocolate colored blood, tachypnea, confusion, headache, dizziness, tachycardia, coma. That's a pretty late sign and symptom. And then O2 sats decreasing despite supplemental O2. So it's going to be diagnosed by co-oximetry, laboratory testing, or implied by symptoms, okay? 2 local anesthetics that primarily cause this, okay, benzocaine and prilocaine. All right, this can produce this adverse effect. So methemoglobinemia, or methemoglobin cannot bind to oxygen or CO2, resulting in loss of the hemoglobin molecule's transport function. This leads to tissue hypoxia. Central cyanosis usually occurs when the methemoglobin levels reach about 15%. So central cyanosis is that blue color that we see in patients when they get very hypoxic. Methemoglobinemia is readily reversed, okay? Must remember this, but by the administration of methylene blue, 1 to 2 milligrams per kilo over 5 minutes, IV over 5 minutes, okay? Total dose should not exceed 7 to 8 milligrams per kilogram. Methylene blue is metabolized by methemoglobin reductase, forming a lucimethylene blue, and this donates an electron back to methemoglobin to form hemoglobin. Okay, so there's your mechanism of action. I would 100% remember the treatment for methemoglobinemia. All right, when we talk about controlled release local anesthetics, this is your Exparel, Depafoam. It kind of got really big a few years ago, and it's slowly fading away because it's not showing any. Studies have shown that it doesn't actually increase your duration as much as people thought initially. So Exparel is a formulation of bupivacaine used for infiltration into the surgical site. It's also very expensive. Depafoam is used in Exparel where drops of bupivacaine are housed in a liposomal suspension. Okay, this leads to the release of the local over several days in a predictable fashion. Max dose is going to be 266 milligrams. But what's important when we think about controlled release local anesthetics and Exparel, local administration with Exparel. So we cannot infiltrate Exparel for 20 minutes after we infiltrate the field with lidocaine. So say if the surgeon just closed an abdominal XLAP wound and they infiltrated lidocaine, we have to wait at least 20 minutes before we could go in there and do a tap block with Exparel. Okay, the reason is that lidocaine that's active in there completely changes the way that this drug is released, so you can end up getting a massive release of that bupivacaine, and we know that that's not good, right? Because our infiltration dose of bupi is 150, but we can see this is higher because of its controlled release. Once we inject Exparel into an area, we can't have any infiltration of local anesthetics for 96 hours after the liposomal bupivacaine infiltration. Okay, so that's important to remember. Tumescent anesthesia is what we use, or the surgeon uses during liposuction to assist with analgesia. All right, tumescent anesthesia is a mixture of lidocaine, epinephrine, and normal saline. So lidocaine for tumescent anesthesia is the max dose is 55 milligrams per kilogram. So extremely high dose. But the reason is they're actually suctioning a lot of this out with the normal saline and back into that canister for injection or to take out of the body there. But the peak plasma concentration of lidocaine is going to occur usually at 12 hours, okay, and it's eliminated by 36 hours. So these patients are at highest risk around that 12-hour mark. So what procedural implications do we have for liposuction like this? Fluid overload, okay, due to the high amounts of normal saline used to assist liposuction of the adipose tissue, and then general anesthesia is going to be recommended if we have 2 to 3 liters or more of tumescent anesthesia solution is going to be injected, okay. So this is something to think about. If you're doing a liposuction case, then you need to know your max dose for lidocaine. So additives that we can put in our local anesthetics. All right, we talked about epinephrine, dexamethasone, and then dextran. All right, supplemental anesthesia, we can put clonidine in there. Epinephrine actually gives some alpha-2 agonism as well. And then opioids, okay. Intrathecal opioids or spinal, we usually use 0.1 to 0.5 milligrams. And then epidural, use 2 to 6 milligrams. All right. To shorten our onset, okay, we're going to alkalize the pH. So we're going to get a higher unionized portion when we inject it, sodium bicarbonate. If we combine it with that, we alkalize the pH. The local increases the non-ionized portion, making the drug more lipid soluble. All right. This decreases felt pain on injection as well. We usually mix 1 ml of 8.4% sodium bicarb with 10 ml of local anesthetic solution. I don't commonly see this, but it's something that you can do. All right, and that's the end of this lecture. As always, if you guys have any questions or need anything, just reach out. I'm more than happy to help.